Why is it controversial? I think it's important to understand the context and the history of food addiction in the eating disorder world. I would say it's controversial in the eating disorder world. This is not something that's controversial in medicine, and it's not controversial in the substance use world. So why is it controversial in the eating disorder world? Because it's been misapplied, and it's been, and you know, in the eating disorder world, there's a lot of dualistic thinking. Like it's either this or it's either that. The same can be said of how food addiction had historically been used and applied. Back in the 80s and 90s, it was something that was treated primarily in substance abuse treatment centers, addiction treatment centers, who, again, because of the way that training happens in our country, people in their addiction training get no eating disorder experience or education. People in their eating disorder training get very little, at best, addiction training. So you have these two camps at kind of polar opposite ends of the world, and what happens to the 50% of patients that have both, right? So back in the 80s and the 90s, addiction treatment centers said, we'll treat food addiction, and by that, they meant anybody who was exhibited out of control eating behaviors or even said they were exhibiting out of control eating behaviors. So some of these people probably had restrictive eating disorders like anorexia nervosa or atypical anorexia, or even binge eating disorder without food addiction, and they were treated as if they had food addiction, which usually meant, you know, very restrictive meal plans, not eating any white flour or refined sugar, weighing and measuring food, very rigid eating diet culture programs. That left people in the eating disorder field feeling like you people over there are hurting patients who have binge eating disorder, bulimia nervosa, probably some with anorexia nervosa, who really need to be working on flexibility, who really need to be working on intuitive eating, and freedom and body acceptance. And the sort of standard nutritional treatment approach in the eating disorder world for all patients is all foods fit for all people. So you have this on one side, and you have the addiction world on the other side. And now you have Kim Dennis coming in, you know, 2005, 2010, here we are in 2022, saying, I think there are some people with eating disorders who have standard eating disorders and who need to be focused on flexible eating, who need to be focused on health at every size, who need to be focused on getting to a point of connectedness with themselves, their bodies, their intuition, which for most patients takes months to years. And then you have subsets of patients who have eating disorders plus food addiction. And those are the patients that are very poorly served in standard eating disorder treatments. We know that we have about 30% of patients with eating disorders who don't get better based on current treatments. So I think for anybody in the eating disorder world to say that's not real or that's going to hurt patients, I understand where they're coming from based on history and based on how black and white it has been applied in both camps. And I think we have a lot of neurobiologic research. We have people in the field who have eating disorder expertise and who can identify what is restricting anorexia, what is bulimia nervosa without food addiction, what is bulimia nervosa and binge eating disorder that really started from a restrictive eating disorder and isn't food addiction but might look like food addiction. You know, and then how do you go about treating those patients? How do you go about determining that? What tools do you use? What scales do you use? What historical markers do you use? There are risk factors that we look for. There are scales that we use, both from the eating disorder world and from the addiction world and from the mental health world. And we tailor treatment to our best guess at what the underlying neurobiology and genes are for that patient, short of having a PET scanner to let us know exactly what's going on in the person's reward center. And we do that side by side. So what I mean by that is a patient with bulimia nervosa and no food addiction, eating their all foods fit for all people meal plan, that, by the way, still respects their biology. If they have biopsy-proven celiac disease, we're not going to suggest that that person eat flexibly and include gluten in their meal plan, because we know it does damage to their body, to their small intestine, to eat gluten. We have that patient eating their all foods fit meal plan, sitting right next to a patient with bulimia nervosa and early life sexual trauma and intergenerational history of addiction in the family and their own history of addiction to stimulants, who has bulimia nervosa plus food addiction. And they're on a treatment plan that's going to help them fully nourish their body in a flexible way, but that doesn't include the food substances that dysregulate their brain reward center and causes dopamine spikes to set them off to a place where they can't control consistently their lives. It's not even about the food anymore. It's about being able to live a free life, a manageable life, a meaningful life with love and respect for and kindness for yourself, the way you're feeding yourself, and how you're treating others.